And now we're going to talk about real policy options. And we're going to begin with eligibility, benefit design, and financial support. I will now turn it over to Henry Aaron and ask him and Marilyn Moon and Bob Reischauer to come up to the podium.
Thank you very much, Alice, and thank you very much for inviting Bob Reischauer and me to do a paper for this event. Bob and I, in turn, want to express our appreciation and recognition of the abundant work that's been done on the very topic we address by a number of people, including some who are here, certainly Bob Berenson, Marilyn Moon, who is discussant for our paper, Karen Davis, whom you all know, Tricia Newman at the Kaiser Foundation, and as Bob pointed out, the entire crew at MedPAC, members and staff who have added so much. The healthcare industry has undergone revolutionary change over the last 50 years. It offers a dramatically better product to people than it did in the past, both cures and treatments, some not even dreamt of half a century ago. It does so also at stunningly higher cost than anyone ever dreamt of 50 years ago. I remember Joe Califano, Secretary of what was then the Department of Health, Education, and Welfare, in the late 1970s, wringing his hands that health care costs had reached the astronomical level of 8% of GDP. Third, medical knowledge has expanded so much that no practitioner can possibly master more than a modest fraction of what is known. And that fact has spawned specialization, which in turn has generated other effects. The need for coordination of care among independent specialists, and changes in the organization of the delivery of care, which is still in its early days, but is certain to result in the delivery of care through ever larger and more integrated organizations. All of this is happening incrementally. It promises to continue to happen incrementally. And if one wants evidence of incrementalism, the best place to look, in my view, the strongest evidence, is actually the Affordable Care Act, which, far from being a radical breakthrough that some of its critics charge it with, is in fact actually quite conservative in building on established institutions to expand coverage. Medicare itself is a vastly better program than it was at its inception. The benefits are better. If you need evidence there, simply say two words, Part D. Medicare Advantage provides beneficiaries with broadened choice among competing health plans, in addition to the continuation of traditional Medicare. Medicare Advantage is now enrolling roughly half of new enrollees and serves nearly a third of current enrollees. Furthermore, Medicare has pioneered in a number of ways, most notably in prospective payments. But Medicare can still be improved incrementally, and that is what our paper is about. So what are the problems that need to be dealt with? For starters, Medicare is actually less generous than the typical private insurance plan offered by large employers. And it's less generous in one particularly undesirable way, specifically that it lacks stop-loss protection. In addition, the ABD division in traditional Medicare is, let's be frank, an atavism. It serves no useful purpose, it's complicated and confusing, and it actually hinders care coordination. The evident desire of most people for more protection to fill in Medicare's gaps is apparent because the vast majority of enrollees in traditional Medicare seek or receive some form of wraparound coverage, and that further adds to complexity. But to make matters a little worse, Medicare actually cross-subsidizes such coverage because Medicare bears much of the added costs for care induced by such supplemental coverage. Well, how do you deal with the problems? There are different ways to do that. Simple and incomplete, least satisfactory and simplest would be to retain the current framework, but require that Medigap plans contain stop-loss protection. Somewhat better would be to add that stop-loss protection directly to Medicare itself, and the reason it's better is that one could have the stop-loss protection be income-related, something that we now are able to do because of administrative demands placed on various programs, including through the Affordable Care Act. Better still would be to offer traditional Medicare as a single plan encompassing Parts A, B, and D with unified administration, a single premium, and cost sharing. Bob and I call that unified traditional Medicare. Best of all, we think, would be something we called Unified Traditional Medicare Plus, modeled actually on a proposal Karen Davis advanced quite a long time ago, that would in addition include coverage now offered through Medigap plans in this Medicare coverage, but it would be financed by additional premiums or cost sharing or both, so that the plan would not add to net costs of taxpayers. Bob especially is keenly aware of budget pressures, and we think those need to be taken into account. Conspicuously absent from our list is premium support, the name that Bob and I gave to a proposal under 19 years ago, actually, under which Medicare would gradually transition into a system where each Medicare enrollee would receive a certificate or voucher for the purchase of insurance in a quite carefully and heavily regulated market. We omit premium support not out of any criticism of Medicare Advantage, which actually shares some of its features and has widespread appeal. It's operating well, and it might well operate even better with some changes, particularly in how the pricing of the bidding for Medicare Advantage plans is done by various companies. We briefly described some of those in our paper, but that topic is central to the Rivlin-Daniel paper, which you will be hearing presently, and so I'm going to pass on from that. Nor, let me stress, do we omit premium support because we think a system along those lines would never work. We omit it rather because from our list of current reforms, because we don't think it should be considered now for two reasons. The first is that the experience under the Affordable Care Act exchanges has been, to understate matters a bit, rocky, and major implementations remain. Furthermore, it's important to recognize that the Medicare population would pose far more daunting challenges to administrators than do those currently enrolled under the Affordable Care Act. The second reason is that choosing among insurance plans is really very, very hard. Research has indicated not once but on a number of occasions that even people who are fully competent consistently make inferior choices, not in their best interests. And dealing with insurance billing in addition to that is quite daunting. Third, the ACA exchanges have powers to simplify insurance offerings and to promote informed plan choice, the kinds of regulatory measures we had in mind when we wrote 19 years ago, but they have yet to demonstrate that they can effectively use them, and we think that capacity should be demonstrated first. Also not included in our list is any proposal to increase the age of eligibility for Medicare. Some have proposed raising it for example, to age 67, in what I believe is the deeply muddled belief that when Congress in 1983 raised the age at which unreduced Social Security benefits are paid, also from age 65 to 67, not yet fully implemented, that legislation provided a rationale for delaying the age of eligibility for Medicare. In fact, the changes in Social Security left the age of initial eligibility for Social Security unchanged at age 62. It left the age at which maximum benefits could be paid at age 70. And by saying that benefits formally paid at age 65 would be available only when somebody reached age 67, what it did, pure and simple and nothing more or less, is it cut benefits. Most people, in fact, claim Social Security well before age 65. And just as an aside, that's a costly mistake. Shouldn't do that, but I digress. The central point here is that raising the age of eligibility for Medicare without simultaneously making people over age 65 eligible to buy insurance through the health insurance exchanges, and at the same time greatly increasing the tax credit support for that age group, would impose a devastating hardship on all but those with the highest incomes, and especially on those whose physical and mental conditions forced them to leave the labor force before age 65. So that, in a nutshell, is our paper. I have just one final comment. The health system has changed remarkably in the last 50 years, but you ain't seen nothing yet. So I fully expect there to be a similar conference at the centenary of Medicare's birth. Given her track record to date, I fully expect Alice Rivlin to be organizing that conference. And I have to say, I hope she invites Bob and me to write a paper for it and that we can do so. Thank you. I am supposed to be a sort of a quasi-chair, and in that capacity, it's my pleasure to introduce Marilyn Moon, who has kindly agreed to be a discussant for our paper.
Thank you. It's a pleasure to be here this morning, and I must say it's a pleasure to have read the paper by Bob and Henry. I'm glad to see they're coming around to my way of thinking a little more than they were 19 years ago when they did premium support. Gee, has it really been that long? That's kind of scary, isn't it? So as you might imagine, there are many areas of agreement that we have that I'm going to talk briefly about. And then I'm going to talk about 3 areas that I think may not be even areas of disagreement, but perhaps embellishment that I think are important to do. First of all, I certainly agree with the concept of incrementalism. As I said a little earlier to some people, the longer you work in the healthcare world, the less convinced I am that massive change is a good idea. We never know exactly what is going to happen from even relatively small incremental changes. And as a consequence, if we go out and try to really throw everything out, we are going to throw the baby out with the bathwater. So problematic as it is in many ways, and I would agree with that, Medicare is still better than many of the alternatives being proffered out there. And that's something that I think needs to be kept in mind. The key question for me is who will be the innovator? that protects beneficiaries, and I see no signs as yet that the private sector is ready to step up to that role. Certainly some are. There are certainly examples of really innovative and wonderful systems, but taken as a whole, I would still put the federal government up there in terms of being a better protector of beneficiaries, which I think is a key issue that ought to be one of the criteria that is used in terms of determining what to do. I also think that before we rely heavily on competition, we need to focus it and control it in better ways. Competition can lead to really good things. As a trained economist, I do believe that. It also leads to pretty wacky and terrible things as well in some cases, when you have people competing for the wrong reasons in the wrong ways. And unfortunately, particularly in something as complex as healthcare, it is often easy for that to happen and to convince people that it's a good idea. The second area of agreement is that simplification is very important. And I agree that Medicare structure is one way in which that simplification ought to take place. And supplementation and the fact that we have this crazy patchwork quilt, in addition to all the supplementation that currently exists for people like me who are still working, but Medicare is primary, and I have secondary retiree insurance for my husband, and I have a flexible spending account. I can tell you the number of catch-22s out there are unbelievable when you try to wend your way through that system. And at a break, I'd be happy to regale you with that. But I think it's also important to point out that there are silos that are created not only by fee-for-service, but by the profit mentality that is out there. The let me do it rather than this other provider. And that whole barrier to coordination of care and the complexity that that adds. My husband recently had a stroke, and what it means is I know now the difference between neuro-ophthalmology and neuro-optometry and neuropsychology and neurologist, and they all want to do the same things in many cases, and they're all convinced they do it better than the other guy, in many cases guys. And as a consequence, it leaves the individual to figure this out. I'm not sure that a fully coordinated system in terms of some of the managed care environments have handled this very well as yet either. Number 3, in terms of areas of agreement, sliding scale catastrophic cap, I think, is important. It's the only way to try to protect low-income beneficiaries in an affordable way. When people talk about a catastrophic cap that seems more affordable, they're talking about $7,000 or $8,000 in many cases. That's beyond catastrophe for most modest income beneficiaries that are out there, and there are lots of them in the $20,000 a year range, and that's just asking way too much of them. Fourth, I think we should definitely reform the Medicare Advantage program along the lines that Henry and Bob talk about in terms of payment. And I would emphasize that we need to bring those plans under greater scrutiny and uniformity. There's some variation that you want to encourage and have competition on. There's other kinds of competition you don't want, and that's more the nefarious type, where people are promising things that are not really good to promise in terms of differentiation. For example, promising people first dollar coverage for certain kinds of care, but high copays for things like home health care, which is the last place you should be putting on additional copays, it seems to me, is something that you should keep in mind, and that's what happens in some of these private plans. It sounds good to the healthy who are there trying to attract to enroll in the programs, and then it becomes a big disadvantage for people who get sick and stay in these programs. This is particularly the case with chronic care needs. Medicare doesn't do a great job, but an awful lot of private plans don't do a very good job either, even just looking at their cost sharing, much less some of the ways in which they coordinate care. Fifth, we should recognize the role of the federal government in quality and disseminating good practices. If private plans come up with good ideas, they want them to be proprietary and they're not necessarily going to share. And that's something we need to keep in mind whenever we talk about relying upon the private sector. Now, my 3 points, I probably have gone over, but I'm going to still give my 3 points anyway. Inadequacy of post-acute care. Our post-acute care system, which is really important for seniors, particularly as they age, and persons with disability, is, to use a very technical term, crappy. It is, there is a very poor amount of coordination. The handoffs are terrible. The knowledge of people in the system about the other parts of the system are very poor. There's a lack of imagination in terms of what could and should be done. And this is an area where I think we could actually see prevention. Better post-acute care will prevent a lot of other later problems, and we don't do it very well. One of the worst offenders is the limit on rehabilitation services, that there's this dollar limit, and when you reach that dollar limit, it doesn't matter whether there's a lot to be done still or nothing to be done. That's the end of that for a lot of individuals. The second area that I would stress is we have to do a lot better with low-income protections. They're very problematic. For the most part, the most generous low-income protections are at 133% of poverty or lower. The only exception is Part D, which goes to a massive 150% of poverty. When these protections were put in place, if you do just inflation and think about what would have to keep up with incomes in order to pay the same out-of-pocket costs to provide the same level, then you're talking about essentially saying we should have low-income protections of something over 200% of poverty at a minimum. This is a disgrace. It is something that is very difficult for a lot of low-income individuals to work within the system. And the problem is, though, when you take it up to 200% of poverty, you're talking about a great number of beneficiaries, since there are lots and lots of them that fall into that category. But nonetheless, I think this is an area, and if I had extra dollars to spend, and there are not many extra dollars anyone wants to talk about these days, that's where one of the places I would put it very early on, because those are the folks who need it the most. I have a lot of objections about some of the problems and the lack of coverage of Medicare, but I can pay, and an awful lot of people out there can't. So that brings me to my last point, and that's one that is going to make me unelectable, but that's fine because I'm not running for anything. And that is that there is a need for more funding. We cannot make the changes that are necessary in this program in a fully cost-neutral way. We cannot, for example, trade off higher improvements in catastrophic protection by raising cost sharing lower down. Cost sharing is already pretty high for this population, and we run the risk then of what I see as a problem with the ACA that gets attention nearly every day, and that is when you have very high deductibles and very high cost sharing, people find that they're underinsured and they're not using healthcare services. We're close to that with Medicare, and we could make it a lot worse if we trade off, for example, substantially increasing cost sharing for individuals as a trade-off for getting catastrophic protection. I think that that's the wrong way to do it. So without more funding, we're likely to do what I would claim, again in another very technical term, wacky things to the healthcare system that we have. There is a temptation to cut in some areas to fund in others, and we may need to do that in some ways, when we may need to be smarter about certain kinds of things. But before we instantly assume that every change must be cost neutral, I think we need to think about where there are ways in which we can add some additional funding to this program. We are going to more than double the number of people on the program. And right now, it's not too bad because Medicare isn't growing very fast, but one of the dirty little secrets about that is because it's absorbing enormous numbers of 65 and 66 a year. We're healthy. And when they get to be 75 and 76, they're not going to be so healthy any longer. And the cost curve is going to go up again, even if we find very reasonable ways to hold down costs on other grounds. So I think we have to look forward. Unfortunately, years ago, I did a little talk in which I said, tax me now, because as a baby boomer, I am at the height of my earnings power, and you can get me before I go on to Medicare. Didn't happen. Didn't tax me as a before age 65 baby boomer. Nonetheless, I think we should still think about ways in which we can add some additional funding to this program to keep it the quality program that it has been over the last 50 years, and to make sure that when Alice does the 100-year anniversary, that we are all here to celebrate it and talk about how it remained a quality program serving the people that it is intended to serve. Thank you.
Thank you very much, Marilyn. Bob Reichauer is going to respond for our team.
Well, just a few introductory comments, and the first being that I'm going to leave Henry to write the 100-year paper by himself. Even if I do take Dana's pills and drink a lot of red wine, I intend to be on a beach at that point and set an example of knowing when it's the appropriate time to leave the stage. But some people, who knows? Also, a quip about Marilyn said she's not going to run for public office, and given who's running for public offices, I can tell you that she isn't age disqualified, and she does have a very important message, namely her third point, which is there's no way we're going to do this without spending more money as a society, a higher fraction of our GDP, to provide adequate state-of-the-art health care to our population and allocate those costs in an equitable fashion across our whole income spectrum. I'm going to be very brief, and that's because I want as much time devoted to questions as possible, and I reached that conclusion after hearing the comments about the inadequacies of Medicare coverage. I'm sitting here with 2 hearing aids, well over $2,000 worth, and an appointment later this month to have a root canal. And I have often reflected on how the bottom half of our income distribution can face those kinds of challenges. And of course, the answer is they don't. And they live with consequences that are only becoming realized now in the psychological and other literature about the quality of life for people who aren't as fortunate as all of us in this room. This room is filled with a number of people who are really expert on Medicare, and they could come up here and present as well as we do, and I'm sure all of them have noticed, and those of you who read the paper later will notice that we've glossed over a number of thorny issues, and these issues mainly revolve around how one implements change of the sort that we have been advocating here. Policy formulation or papers like this are really easy to write and easy to talk about, but the tough part is implementation. Sort of what can you get through Congress? What can you administratively administer? And, that we tried to sort of confine ourselves to things that we really did think over the next 15 years were feasible. But to sort of convince people of this, we would have had to have written a 400-page book, as some people have done, on that topic, and it's subject to a huge amount of uncertainty. It's also worth reflecting on the fact that the solutions to yesterday's problems also become the impediments to solving today's problems. And if you just think about it, we have over the last 30, 40 years expanded, standardized, et cetera, the Medigap options. And so that is a robust component of the insurance industry. And there'll be a lot of reluctance on the part of insurers to changing that, as we have suggested, and also some reluctance on the part of nonprofit organizations like AARP, who have done a lot to stimulate the demand for this and profited from it. There's also the issue of Medicare Advantage, which started small, sort of a niche type of operation, and because we had excess payments and folks were receiving ancillary benefits or lower premiums, understandably, those in the parts of the country where coordinated care was not economically feasible said, hey, let us into the game, and we then expanded what you could call Medicare Advantage to private fee-for-service plans and other forms, and they will be an impediment also to some of the changes that we have proposed. Not to mention the Part D program, which was solving the problem that we had that Medicare didn't cover prescription drugs, and to get the kind of political support that we needed for that, we allowed the private sector to offer plans that really were unlike the plans that they were offering now, which are basically for employer and other purchasers, and they serve as PBMs, that pharmacy benefit managers, that comply with the integration that the purchaser, mainly the employer or the union, want. And we have this standalone plan, which, as was described by the first panel, we have a few paragraphs in there about this, has financial incentives that maybe aren't the ones you would want to provide the best overall health care. So we have to think about what we are putting forward and where the opposition will arise from, and think of ways that can get everybody on board. Just to mention two things which we didn't get into, and they're very complex issues, and one of them is to think about how we set premiums for our Unified Traditional Medicare and Unified Traditional Medicare Plus points, and the extent to which we would tolerate differences in premiums between these plans and the follow-on plans to Medicare Advantage. And then the second really thorny problem, which is whether at some point over the next decades we should begin varying premiums by the differences, the justifiable, the unjustifiable differences in Medicare costs across geographic areas. I was a member of the Institute of Medicine panel on that issue, not the solution, but the extent to which costs vary and what the explanation of them is. And of course, some involve cost of inputs, small, able to ignore largely. Some are the health of the covered population, some relate to the quality of care, some to the efficiency of the delivery system, and the extent to which low-value or no-value services are provided differentially across the country. And at some point, I think if we want to spur efficiency, we're going to have to begin to grapple with those questions, but they are not ones that we covered in any depth in our paper. So with that, I turn it back to our chair.
Have a seat.
I
and,
will return to my chair.
We will go directly to questions from the floor, because I think each of us talked a little longer than we were asked to do, and we've eaten into the time for questions from the floor. So, yes, sir. Microphone down here, please. And would you identify yourself and end up with a sentence that has a question mark at the end?
Hi, I'm Fred Altman. I'm retired. And my question is, you know, one of the options you're talking about is increasing the money going to Medicare. But there's already concern that we're spending too much public money on the aging at a cost of not providing adequate public funding for younger generations. Do you want to address that problem?
I personally believe the problem is if you give more money to the aging, then there should be less money for the very high income population in the United States. I've looked at this issue for years, and even within the Medicaid program, where you would see a direct trade-off potentially, I don't see that if you cut programs for seniors, that it translates into higher payments for kids. That's not the way our political system works. When we cut, what we do is then tolerate lower taxes over time and congratulate ourselves that way. So I think rather than accepting the premise that we're pitting the old versus the young, we have to think about where we want to have resources and work on that way. I have no problem, for example, with the notion that if we're going to increase taxation in some way to help seniors, that we should do that with an equally large piece of money that goes for helping children in some way. But I just think it's often this false dichotomy.
Bob, do you want to? Other questions from the floor? Yes, ma'am. You can come in again.
Yes, good morning again. With the recent legislation that passed, there was a provision that GAP plans, as I understand them, would no longer cover the 147 deductible. So I have two questions. One is there really thinking out there that people in their 75 and 80s are going to the doctor unnecessarily, and this will prospectively make them more conscious? But second of all, I wonder how many people understand that most GAP plans have age bump ups. So you may be paying a certain premium when you first sign into it at 65, say $2,000 a year, but that may become $3,000 or $4,000 or $5,000 a year at various incremental ages. So they're paying significantly more so I wonder how many people do you think really understand that, and also about the $147? Thank you.
I think very few understand that. I mean, there are three ways in which an insurer can set the premiums for Medigap plans, and one is the age of enrollment, one is the age of attainment, and the third is community rated. And of course, people can change from one to the other as they go through time by choosing a different plan. But I think you put your finger on sort of one of the complexities of this whole area for public policy, which is the vast majority of people have very little idea of what they're buying and what the conditions are. And not to embarrass anybody on the Brookings staff, but I received an email from a prominent Brookings researcher. I was a Brookings researcher once, so I do this with pain, saying, how does this whole thing work? I mean, I can't figure this out at all, and it's because it's so complex, and that's one reason why Henry and I and Marilyn before are saying, we should really condense these things together and give the elderly the same kind of situation that the vast majority of all Americans with insurance have, except the elderly and the disabled, and that is you buy one plan, and it is comprehensive and covers everything, and the premiums are set, and the method of choosing them doesn't change. The $147.90, I believe.
But who's counting?
The deductible is that last 90 cents. I think you're right that that isn't going to discourage a whole lot of utilization. I mean, you can hardly say hello to the receptionist in the doctor's office without getting billed for $147. It's basically a way to gain money to use for something else. That's what it is.
I've never believed that the $147 is going to do anything to change the use of healthcare services. That said, it's not so terrible as $147. My concern is if we move to a combined AB deductible, for example, that's going to definitely be more than $147. Then you start to talk about a $600 or $700 deductible potentially. And if you're saying no one can buy protection against that, it could become a deterrent. And the unfortunate thing is that's a deterrent where you don't really want there to be a deterrent. The real healthcare spending occurs when you're well beyond $600 or $700 or $1,000. And we need a lot more careful attention to how we're spending, but that's not going to be controlled by individuals worried about their deductible.
That raises an important point, which is that good insurance, along with higher deductibles, frequently has carve-outs which are not subject to the deductibles. But the emphasis on the details of implementation, I think, cannot be overstressed. Just about my favorite quote on this matter dates back to somebody whom some in the room may be old enough to remember, Wilbur Cohen, who said that good public policy is 10% legislation and 90% implementation, which is a point that I think Bob was making, and that cannot be overstressed again. Bob referred to the email that he received. I'm going to describe the lunch table conversation that occurred yesterday that either followed or preceded that email. It involved 4 or 5 PhD economists, one of whom had without blowing his cover, a high position in the Federal Reserve System, others of whom had held high government positions of various kinds. The whole discussion revolved around the fact that one of these people is going to be going off the Brookings payroll at the end of this month, and will then have to make a decision about whether to take the Brookings supplemental benefit plan, which used to be generous but isn't anymore, very carefully designed to achieve that result. I speak with genuine emotion on this subject. Or one of the plans on offer in the commercial sector. And none of us was able to give good advice or really weigh the choices very well. We all are relatively passive buyers. We're like, in this respect, the Nobel Prize economist who, when asked how he plans his investments, he said, I just put them into index funds. This is an area of great complexity, and there is a really deep question here as to how much choice is really optimal for people to have. Some, yes. Too much, people disagree about how much is too much, but it isn't the maximum amount of choice possible. This is a very complicated area, and one in which the design of policy is hard enough. The implementation of policy is even harder. We are going to be passing on to the next session. I think we've used up all our time here. And thank you, Bob and Marilyn. And we look forward to the next discussion.